Well, so welcome to everybody. I will start sharing my screen. My name is Filippo Santorelli, and I'm a coordinator of the Young Investigator Training program. We have a very challenging program for young trainee for neuromuscular conditions. And we started already in 2024. This is the second year. If you are a young clinical fellow or resident or young scientist interested in neuromuscular disorder, please take advantage of the training program. We will have multiple webinars. Of course, you can attend the webinar in person, virtually in person, or you can download the record of these webinars. We welcome Professor Schoser. We just met us. Today is our major presenter for major speaker for the topic of today. If you are a young investigator and are interested in neuromuscular disorder, please visit our specific page and register to our program. In the following month, we will have additional webinars. One is supposed to be at the end of September and will be on detailing how electronic magnetic resonance imaging data can be recorded. Or in October, we will have a more similar webinar on genetic data. And then in the spring of 2026, we will have a final webinar on the Atlas, that is a major toolbox made possible by the CoMPaSS project. At the end of summer, the 2026, we will have a final summer school. That said, I like to introduce the coordinator, the Professor Tupler, who is the coordinator of CoMPaSS-NMD, and Rossella, the stage is yours. We can't hear you. We need your microphone on.
Good afternoon to all the attendees. I am glad you are participating to this second year of this training for young investigator. And this is related to one of the goals of CoMPaSS. CoMPaSS is a computational model, stands for computational models for new patients, stratification strategies of neuromuscular disorder. So the next. Can I have the next? So most of you have already attended to the class last year. We have newcomers, and this is just to introduce the rationale for this project, because we know that muscle disorders constitute a huge number of patients with hereditary myopathies, but most of them, 60% of them, do not receive a proper molecular diagnosis. So starting from this expertise and starting from a collection of data that had occurred through several European projects, we started and we developed this new project in which we want to first put together a different data set, meaning the DNA, the precise description of patient, the histology, the data from the magnetic resonance of MRI of the skeletal muscle, in order to help in creating algorithm through AI that can help in stratify these patients. The second part of the proposal, because now we are at the end of this first part in which the Silesian University of Technology and the group of Professor Polanska has already analyzed and designed algorithm for this for CoMPaSS, so new tools to stratify patients. Now we are entering in the new phase. In this phase, we are recruiting patients that do not have a diagnosis, and we want to analyze them collecting clinical data, MRI data, histology data, and genomic data from each one. This in order to validate the algorithm that has been developed in the first part on the retrospective data, which is the goal, the final goal of the patient. On one side, we will have an atlas, so a tool that will collect also in the future new patients. So it will be a tool available for other clinicians, for other researchers in order to study neuromuscular disorder. And also we want to see if we are able to make more precise diagnosis, stratifying, so subdividing the patients on the basis of all these parameters and the algorithm designed by SUT. So this is the second part. What is very important, and this is what I want the young investigator to know, is that we really would like to have a new generation of scientists that are going to, that will be able to interact. Meaning that we want to have doctors, geneticists, biologists, and computational scientists able to talk in order to use the tools that and the expertise that each group, each specialty provide in order to advance our knowledge. In this case, in the field of neuromuscular disorder, but it can also be a good example for a new strategy to approach rare disease patients. Thank you very much.
Thank you.
In the next slide, we will have the connection for the recruiting. If you have patients, if you want to talk to us. Thank you very much.
Thank you, Rossella. So if you are interested in joining us in CoMPaSS, there is a way to contact Rossella as a project coordinator and eventually to recruit your patients to CoMPaSS. Now I will stop sharing my screen. We move to the major topic of today's presentation. Professor Schoes. I will not introduce Benedict because Benedict will introduce himself in the recorded presentation. So Annalisa, you can go on, and at the end of the presentation, Professor Benedict is willing to answer us to some potential questions from the audience. Go ahead.
I welcome you to the webinar part of the CoMPaSS-NMD program. What I'm giving you today is an introduction to muscle histology, and in the second part I will introduce you to Atlas Histology section. My name is Benedict Schoes, adult neurologist working at the Friedrich-Bauer-Institut Department of Neurology at the Ludwig-Maximilian University in Munich. If you have any additional question, please let me know and send an email to my 2 talks. By this, I thank you, and this will now be followed by the introduction to muscle histology. Dear all, this is a brief introduction to human muscle biopsy diagnostics. This is part of the work package 2 of the CoMPaSS-NMD EU-funded study, and is part of the atlas we create. At the beginning, let me introduce you to the key diagnostics, what muscle biopsy is still ongoing. So we have clear indications for inflammatory myopathies, some of the recessive muscular dystrophies, the metabolic myopathies, congenital myopathies, and we use conventional stainings like the hematoxylin eosine, the trichrome gomery, ATPase is at different pHs, NHD, SDA, COX, SDH, and PRS, all red, etc. We also can use immunochemistry to look for cytokine proteins. We can do biochemical analysis. We can go for biomarkers nowadays with RNA sequencing. We can go for Western blottings, and finally for electron microscopy. Mostly today it's more a secondary diagnostic tool, and we first go for imaging and gene panel analysis, and in the second step we then sometimes need to do still muscle biopsies. So first of all, what is the selection of a muscle to be biopsied? In chronic disease, consider a muscle with moderate and not too severe weakness. In acute diseases, the muscle with severe or moderate weakness. Best specified muscles in our collections is the deltoid, the biceps, the quadriceps, and the tibialis anterior. If you want to go for difficult cases, use MRI or ultrasound to select the pathological muscle site for the best place for the muscle biopsy. Please avoid that the muscle is traumatized to EMG, to injection, or any other type of trauma. So how to take a muscle biopsy sample? There are different techniques. One is the so-called open technique. I show you here in the picture. So you localize the muscle by the clinical syndrome, EMG, ultrasound, MRI. Then you do a local anesthesia just to the muscle fascia. And normally you need to take out at least 30, best 50 milligrams. Do the observation for the different things I show you in the next slides. In infants and also for clinical trials, you can use needle biopsies, especially also if you want to do follow-up studies. Here's an example of muscle needle biopsy techniques we use for our clinical trials. It's a new device. Normally you'd use it for breast biopsies. This is well done. It was introduced very early in 1861 by Duchenne. Later on we used for a long time the Bergstrom needles. But now we have this modern technique that's much better. Infiltration to the skin, and then you do an incision, introduce the needle, and you can reintroduce to take up to 5 samples, and then you have the butterfly dressing, and normally you can get from the needle biopsy up to 30 grams. On the next slide I show you what is a classic EMG artifact in a muscle biopsy. You see here in these parts necrotic muscle fibers, very classic, surrounded by normal muscle fibers. So if you take a biopsy, go for a contralateral muscle to the EMG investigation, or at least 10 centimeter distance from the EMG needle insertion. What is the size you normally need? Here I have an example. So it's a small block that you use for histology. You need another small block for any biomarker or biochemistry or RNA sample, normally 20 milligram. Here you see regular red fibers. And I also like to introduce you to muscle cell cultures, tissue cultures. So therefore you need your growth medium, so-called solution A, and you need a tiny little piece. Then you can culture muscles and even later on immortalize them. Furthermore, you can go for a sample size for electron microscopy. Also, this is a different type of solution where you store it, but also this is still worthwhile to do. And here you find a summary of the classic histopathological stainings we are doing, and of course for CoMPaSS we use only the hematoxylin eosine and also trichrome gomery. In total, with 50 milligram, you can do all these 15 stainings. Okay, so what does the normal muscle look like in H&E staining. You see its polygonal shape, normally a size of 60 to 70 micrometers in square, and there's hardly any big fiber variation. So therefore the dark dots in the corners, these are very classic, the nucleide, and in white here at the top at 1 o'clock, this is an artifact. If we look for inflammatory things, then we see clearly here inflammatory parts, lymphocytes invading the muscle fibers. You see even then more internalized cells in addition, and also in between you see an artifact that's spacing out in these H and E sections. If we look for more details, you might find some supervacuolated fibers, tiny vacuolated fibers, or then an increase of connective tissues. These vacuoles you see here, they are definitely not artifacts. I come to this back later. On the other hand, if you see tiny angulated muscle fibers, then normally here's the nerve or motor neuron affected. So in here you see the so-called angulated atrophic fibers, and most likely it's a neurogenic process like the ALS. Another change is if you see more connective tissue and if you see fat. So here you have more round-shaped fibers, you have an increase in fiber size variation, you see small and large fibers, and you see definitely an increase of connective tissue and also these white holes. This is fat. Let's move to trichromacy stain. Here first you see a norm muscle, so you see a bit more subciliary mitochondrial. That's the little tiny red staining in these fibers, but normally it should be very pale, similar stain. If we have this exaggeration of mitochondria, as here in the ragged red fibers, you clearly see this is something you can pick up in the trichromacy very nicely, and this gives you a first clue that this could be a mitochondrial myopathy. If we see these dark stained things, so we call them inclusions, and most likely these are nemaline bodies or rods, depending on their size and on their frequency, you pick them up. And this is a sign of rods or nemaline myopathy in different genetic disorders. So here a very brief and short histological guide. First of all, to just decipher is this a more neurogenic or myopathic process. You go for more round fibers. So this is myopathic angulated fibers are neurogenic. There's a very few exceptions. If you have a type 2 fiber atrophy, then you have very small angulated fibers. Spinal muscular atrophy, also here you have sometimes small rounded fibers. Next step is the distribution of atrophic fibers. So are they grouped? This is mostly in denervation, but also in dystrophinopathies, or they can be scattered. This is acute neuropathy or also acute myopathy. Then we have another thing is the distribution of fiber types. I come to this later. So there's a grouping. This could be chronic denervation, or you have a fiber type predominance. This is sometimes for congenital disorders. Then a fiber type smallness. So if you have small type 1 fibers, this calls for hereditary myopathies. Small type 2 fibers, mostly acquired myopathy, sometimes congenital myasthenia gravis or mitochondrial diseases. And then the other thing is you need to decipher first line, is this acute or chronic happening in your tissue? Acute in myopathy, you have myofiber degeneration and regeneration. In neuropathies, you see small angulated muscle fibers. In chronic issues, you have an increase of endomysial and perimysial connective tissue and a hypertrophy of muscle fibers. In neuropathies, there's normally then a fiber type grouping. You see sometimes also pycnotic nuclear clumps. Here's a Fangison staining. You see here in red, this is connective tissue, and also here some white labeled fat cells. This is something. Here's a Fangison staining. You see here in red, this is connective tissue, and also here some white layer. Another stain you use are ATPases at different pHs, so you can label different fiber types. Here's the standard staining at pH 9.4, and you see the black ones, the dark black ones and brown ones, these are the type 2 fibers. The light brown ones are the type 1 fibers, and you see even interim fibers, these are the so-called type 2C fibers. And if it's a type 2 fiber atrophy, you see a picture like this. Another stain you use are ATPases at different pHs, so you can label different fiber types. Here's the standard staining at pH 9.4, and you see the black ones, the dark black ones and brown ones, these are the type 2 fibers. For what is this good? Here, just to give you an example, it is the neurogenic processes. There's ALS, the post-polio, and the spinal muscular atrophy. And there you clearly see that there's a fiber type grouping here in the middle section at the post-polio syndrome. And also you have in the ALS trophic fibers of both fiber types. They are angulated. And in the SMA you have fascicular atrophy, but also in the fascicle is some fiber type grouping, more of small scales and size. We have more stainings like the southern black or oil red staining for fat. Here you see it in the southern black staining. We have more stainings like the southern black or oil red staining for fat. Here you see it in the southern black staining, better improved if you go here for the situation where you perhaps have a lipid storage myopathy like the Q10 myopathy. Here you see these microvacuolated fibers, and if we go for these type of stainings, you see here clearly lipid storage. So all these black microvacuolated stuff is lipid, and if you go here on the right side to the electron microscopy to see the lipid storage clear cut in these fibers. What is periodic S Schiff staining good? Here you see in the normal muscle you can also decipher the two fiber types, and you see here the normal glycogen content of both fiber types. What is periodic S Schiff staining good? Here you see in the normal muscle you can also decipher the two fiber types, and you see here the normal glycogen content of both fiber. And here in extreme, so on the right side you have infantile Pompe disease, and on the left side it's adult onset Pompe disease. You see the different stainings of PAS in these both situations, and the vacuolation, and of course the load of glycogen in single fibers. If you want to be really sure with Pompe disease, you also need to have acid phosphatase staining. Here you even see earlier the vacuolated lysosomal dysfunction, and here's a stain of a mildly affected, a moderate, and an infantile onset on the right side of Pompe disease. What else can we stay? Of course, we look for NHDA, so that's a mitochondrial marker, and you see a subcircular mal, tiny little mitochondria. It's labeled, but this is all the normal stain. You have here also the two fiber types you can easily decipher. And go for a so-called CoX-SDA staining. You see CoX negative SDAs, positive fibers. They are up to 5% in the aged populations normal. But if you have an increase over 5% in a younger age, this definitely calls for a mitochondrial disease, and you can then go for specific extra investigations. And another example, what you can read in muscle biopsies is, of course, sometimes what we call the structural congenital myopathies. Here an example of central core disease. You see clearly these round cores in the trichrome staining, and this gives rise in the electron microscope that you have unstructured cores here in the lower part, and this is the clinical phenotype of a lady I know and a boy since many years. And of course, still muscle pathology is super important for the differentiation of different types of myositis or inflammatory myopathies. Very classic in the middle row, that's IBM. You see here little inflammation, you see vacuolation, you see a widespread of different fiber types, you see angulated fibers, and that's the giving call now no longer due to the new NMC criterion needed, that you have these inclusions. Some of them can even be intranuclear and round fibers as well, and rimmed fibers as well. So that's the classic middle part. On the other side, you have the formerly so-called polymyositis, very rare. There are many overlap myositis or PM-METO types of findings, but one of the interesting things is if you do immunostaining, then you can see here invading lymphocytes, CD8 positive lymphocytes into a muscle fiber, and that's the hallmark of an inflammatory myopathy. On the left side, you see the so-called perifascicular atrophy in dermatomyositis, more clear if you stain that with a CD4 marker, and in the lower part you see these type of vesicular inclusions you see in the vessels of dermatomyositis. So also complement inhibition is here an issue for this type of disease. Finally, let's come a quick introduction to limb girdle muscular dystrophies, diagnostics by muscle biopsy. Of course, we have different membrane proteins and also intercellular proteins we can label. One example, very classic example of what you are doing. If you see on the H&E here on the top row that you have a dystrophic pattern with increased connective tissue and on top also fat infiltration, you can do a regular immunostaining for different proteins, and to further control this you finally do a Western blotting, and then you can see if you still have the protein or if it's degraded, like here in the different types of stainings I present here to you. And a very classic thing is here for the Becker-Keener muscular dystrophy, the BMD dystrophinopathy. You see here the accelerated calf syndrome well, and if you do a Western blotting here, then you see here on the first two rows in the middle normal control, and there's a completely loss of the protein. That's a dystrophin case, but if you do it in the patient here, then you have a partial dystrophin deficiency still there, so it's a change in molecular weight, and this gives you a classic diagnostic step for looking then for dystrophin gene mutation. Welcome to the Introduction to Atlas Histology section. If you start, please log in to the Atlas platform. There you will find the data collection overview site, so that's here the labeled red one. If you go there and have logged in, you will find your file. So I take the lowest row here, Ludwig Maximilian University, and here you have to move to tissue scan. If you click on this, then there will be two more items coming up. So you can show tissue scan or you can upload tissue scan. This will move you to the next section. So if you go there, then you come as next to the histopathological overview part of it, and if you click there on it, then you come to the histology evaluation form. So that's here the details. You see there the upload date, the collection date, you see which type of tissue imaging you loaded. You take here the muscle biopsy, you can then see the size of your file, and you can label here if it's an open biopsy tissue, was frozen, not frozen, paraffin embedded material, formalin fixed, yes, no, handling, and of course you have here the chance then to label it for the trichrome or the H&E. You can upload other types of files. Please use NPD high resolution files or TIFF files. That's the only two you can upload. If you then go to the evaluation form, then you select an evaluation. So you will add here on the green button evaluation, go to the next file, and this will open the next part, the so-called histopathological evaluation form. You see here labeled the ID of your patient, and then first of all you look for the tissue and look for ice crystal artifacts, and then you start to really look at your tissue. Here, for example, I put it in H&E. That's a normal finding here. And you look for if you see any type of inflammation, if you see any type of specific changes. But first of all, you'd like to just label if it's a normal sized or atrophic or hypertrophic fibers. Are there any other aspects you'd like to mention here? And then you click to this. And the lower part of this is coming to myopathy-associated pathological structures. You see different types of changes in the fiber. I put here a trichrome fiber, and you see clearly here some rods and namolines, so you can specify here on the section here that you have seen namolines, and you put that into the form and label this as positive. And that's all. And then you add the evaluation. Finally click here to the blue button, and then you have done your histology evaluation form. And by this, I thank you for listening to me, and if you do have questions, send me an email as here on the left side. Bye-bye.
Thank you, Professor Schlosser, for this detailed description of muscle histology and how we can benefit of the Atlas Toolbox to analyze in a different way muscle histology. Now the presentation is open to discussion. So if are there any, I don't see any question in the chat, but if some of the attendees some question, want to some details or some clarification, Professor Schlosser is here with us. Any question?
Before questions coming up, I can add, of course, one of the key elements for all of us, our eyes and brains are really easy about artifacts. So we got to know them and immediately ignore them. For beginners and learners of muscle histology or any type of stainings, if you do it in any type of tissue, it's the big hurdle at the beginning. And this is also, we realize already, one of the big hurdles for our AI approach on this. So for us, we extract this rather easily and see the details and ignore the artifacts. And that's something we need to train and teach AI as well, that they are getting that ignorable as we are. So this is an important point. And of course, we start with only 2 stainings, so that's a little limitation, but at least it's a good point. And as we decided to go for these H&E and trichrome stains because they are easily to be performed everywhere around the globe, we always were considering that Atlas should be a helpful tool for all dimensions, even in countries with less income, so that they can join us and can give us details on their patients, and we try to analyze them. I think that is very important, perhaps, to point out here as well.
That's really a good point. I have a question regarding the open biopsy. Okay, you say, well, perhaps a needle biopsy is feasible in a follow-up, but from your experience with the new tools, can you perform a complete histological assay, immunohistochemistry, and still keep tissue for RNA, for tissue culture, and for long-term storage? What is your experience in terms of needle biopsy?
It's a very good question. Of course, you can do that really with now the modern needle biopsies. So it's performable, but the only thing that is normally then declining is the quality of the cross sections. So that's the one element I see. But if you really go for more protein related or immunohistochemistry related analysis, and even then for biochemics or molecular analysis, then a needle biopsy is good enough. We know it now pretty well from the clinical trials. So there is what we do. But if you want to have the pure traditional good histology, so then there's some limitations still, even with the new needle biopsies, because the cross sections are really small, and that's something you need to consider. Sometimes for the infants, it's always good. I think for infants, there's no longer really a need for open biopsies because the diameters are a bit smaller. So then you have at least 200 fibers. So that's what you need for a cross-sectional area that you have a superb readout. And that's doable in the infants rather well. But in the adults, it has still a little limitation. But I think, well, our combined readout, what we want to do with clinic, MRI, genetics, and histology, in the end, we want to see if we can play around and have only perhaps left 2 of them and not all 4, or at least 3, and then can get rid of 1 and only in exceptional cases. So that's the way, well, we hope to go with CoMPaSS-NMD, and all the brains here on the screen and beyond, they try to work on this.
Thank you very much. Other questions? Okay, I take the advantage of my position as the chairman to ask again. One more question is regarding, usually some fellow ask, what's the best muscle to biopsy? So should we take a biopsy of a very atrophic muscle or a weak muscle, upper limb, lower limbs, better the biceps rather than the quadriceps? What is your experience? Can you share with us your experience?
Yeah, a very good question, Filippo. Of course, you know that pretty well. It depends on the situation. So if it's a very chronic situation, you're in more than 1 year of already weakness, of muscle atrophy and things like that. So here I normally recommend to have some imaging before you do the biopsy. Because what can happen if you take a biopsy of a highly atrophic muscle, then you hardly see anything. So that will be end-stage myopathic, where even you can't decipher from an end-stage neurogenic process. So the end stage for both disorders looks sometimes very similar. So therefore, be aware of this. So a highly atrophic muscle is not recommended. If it's a very chronic disease, do ultrasound or MRI imaging before you perform the biopsy to really consider what could be the best readout for this is still both are invasive treatments, so therefore you need to consider what you are doing there. So normally, if it's a very highly acute situation, then you would take a muscle that has at least weakness, but is not highly atrophic. So that would be my recommendation. And this belongs more to the clinical situation than really to the workup. So the easiest one, because it's a huge bulk of muscle, is the vastus lateralis muscle. That's normally also done in the infants. Or the other 2 highly recommended is the tibialis anterior muscle or the gastrocnemius. In the adults, I always say gastrocnemius is not that nice because a lot of lumbar disc pathology can display there. So that is one of the issues. So therefore, I normally don't recommend to go for the gastrocnemius. There is the French way in doing muscle biopsies. I always recommend it's the T-shirt line. So therefore, you go for the deltoid. That's a very good muscle for if you have inflammatory myopathies. And that keeps, if you do an open biopsy, the scarf very tiny, very thin. So therefore, many of the French muscle people do the biopsy out of the deltoid. And the other well recommended in some of the metabolic diseases, also the biceps brachii muscle. So that's the regular one. I would be very careful with very unusual muscles because there you normally don't have really the full normal readout of patients. So that's something, if you go for smaller muscles of the lower arm or even in the hand muscles, you can of course do that. But then it's rather vague because the reality is. So sometimes what we don't use in the regular routine workup is going for the biceps femoris. So that could be a good muscle in some of the metabolic diseases, But here I strongly recommend to have, before you go in this direction, have a ultrasound or a muscle MRI.
And if I can add also, just consider what is your experience with control muscle. If you have a large experience with control muscle from the biceps brachii, don't start biopsying the deltoids. Don't mess up. Muscle is not always the same. So,
Yes.
and even muscle fibers are not always the same, even metabolically.
Yeah, I agreed.
Are there other questions for Professor Schröser? No? Okay, so we thank you, Benedict, for your time, for your excellent presentation. In case you guys have a question for Mr. Schröser, by taking the record of this presentation, there is Benedict email, so you can email and send us some details of what he commented today. Then we go to just a conclusion. So just to remind you that the Young Investigator Training section will continue. We will have, as I said, another webinar in September, and then October in the spring, and we will conclude with a summer school in 2026. Annalisa from CoMPaSS group will send soon some more precise details on September webinar. That said, I thank you all. We are perfectly on time. We had said 45 minutes. It's 45, 15 to 4. So very good, German style. Okay. And thank you, guys, and see you soon next time in September. Thank you again.
Thank you so very much.
Thank you.
Thank you, Annalisa.